Dr. Rafia, you can join in. We are live on YouTube.
Audio.
Assalamu alaikum, everyone. Before we start with this webinar, let's remind ourselves the importance of reading, knowing things and sharing that knowledge. As Allah subhanahu wa ta'ala has communicated to us through our beloved messenger, Prophet sallallahu alaihi wasallam, in the form of Quran, Iqra, Bismi rabbika allazi khalaq. Read in the name of your Lord who has created all that exists. Let's bond over sharing this knowledge that we have within ourselves for the betterment of the people around us. With this, good evening, everybody. I'm Dr. Rafia Rasool, Guru, your host and moderator for the evening. Before I move on to introducing our speaker to you, I would like to inform you that we'll be taking questions towards the end of the session. I request you all to post them in the chat box. Also, it would be great if it's more of an interactive session, as we have amazing clinicians in the audience, and we would like to get most out of this session today. So today's webinar, as the title suggests, is quite common occurrence that we deal with in our clinical practices, dental veneers versus orthodontic intervention. And to talk about that in detail, we have a brilliant speaker, Dr. Sana Taher, with us. Dr. Sana is a practicing orthodontist in UAE and is an alumnus of VS Dental College, Bangalore, who is accredited with implant courses from India and South Korea. With overall 13 years of experience, Dr. Sana handles various orthodontic and general dentistry cases. She takes a lot of joy in treating young adults and adolescents with a holistic approach and concurrent counseling sessions with her patients to achieve the best results, maintaining the aesthetics, the functional, and psychological well-being of the patients. She believes in a positive outlook for a more positive outcome. Without any further ado, I request Dr. Sana to take over the podium. Dr. Sana, over to you. Thank you.
Thank you so much, Dr. Rafia. It was a very beautiful introduction. I'm very, very humbled by it. At the outset, I'd like to thank GDP for giving me this opportunity to talk about this topic, because this is a very common topic and a very common thing that we encounter in our clinical practice. So thank you very much, GDP. Thank you, Dr. Garcia, Dr. Rafia. And without further ado, I'd like to share my slides. I'm going to share now. And can you see that?
Yes.
Let's begin. Dental veneers versus orthodontic treatment. Introduction. I'm just going to give a brief differences. Dental veneers offer a quick way to a beautiful smile. They can help change the shape, size, and shape of the teeth. Versus orthodontic treatment. Orthodontic treatment is used primarily to correct misalignment, malocclusion of teeth. It improves the bite and functioning of the overall jaws, whilst improving the dental and facial appearance. So orthodontic treatment also helps in the functional aspect of chewing. The definition of laminate veneer restoration: a conservative, aesthetic restoration of the anterior teeth to mask discoloration, restore malformed teeth, close diastemas, correct minor tooth alignments. So this is very important. It can correct only minor tooth alignments. As an orthodontist, I really pinpoint that more. Indications for veneers. 1 second. Okay, when teeth are fundamentally round, but they're discolored. So there's discoloration, innate stains. That's when we'd say go ahead, go with veneers. When there's hypoplasia, when there's fractured teeth, when there are tooth wear lesions like erosions, abfractions, etc., and when you have to modify the shape or close minor spaces. So sometimes in midline diastema, for a fast and quick result, we do use veneers. But as an orthodontist, I always prefer to go for orthodontic treatment. But there are situations where veneers have been very, very helpful, have been a very good and quick solution. The types, resin composite and porcelain. Now, these are two cases where we can see, in the first case, we can see there is a missing central incisor, and the other central incisor is also chipped on the incisal edge. In this kind of a situation, I would, we need veneers to give that aesthetic appearance, to change the lateral incisor, to look like the central incisor, and also so much of discoloration. The central incisors don't match with the laterals and the canines, so the color matching mismatches there. So that can be solved with dental veneers. Now we have the other case here, where you can see the shape is not very satisfactory and definitely will not give a pleasing smile. And there's a minor amount of spacing, and this person is a good candidate for laminates or veneers. So these cases would be good for just dental veneers. Again, here in this particular situation, which is very often we have encountered, where you have an anterior filling which consistently and constantly fractures. So because it's an anterior filling and it's in the midline area or incisal edge area, and it's chipping again and again, it's getting discolored and you're not happy with it, then yes, then you can go ahead with dental veneers in this situation. It gives a good aesthetic result, and as many prosthodontists in our forum will agree with. Now I will go on. This was just very brief about dental veneers. I have not gone into a lot of detail about it. However, I will go into a bit more detail into orthodontics, because I'm an orthodontist, obviously. So orthodontics, let's begin with the definition. The British Society of Orthodontics in 1922 defined orthodontics specialty as orthodontics includes the study of growth and development of the jaws, the face, particularly, and body in general, and influencing the position of the teeth, the study of action and reaction of internal and external influences on the development and the prevention and correction of arrested and perverted development. This is a straight textbook definition. I'm not going to go into it. We've studied this in our undergraduation as well. Indications. So here I'm going to go into a bit more detail. Indications of orthodontic treatment. So you have several. You have psychological, you have developmental, you have functional, and then you have trauma and disease. Now, psychological, when I go into the details of psychological, when do I know this is a psychological indication? It's the minute the patient walks into my clinic, the minute the patient walks into my room. So what happens when a young patient or any patient walks into my room and they're trying to smile and they're not smiling? The most common thing that I've seen with people is that when they're trying to smile, they cover their face. So they're not confident. There's lack of confidence. That is the first sign. That's the first sign that I see if someone is trying to hide their mouth when they are smiling or laughing. So they're not comfortable showing their teeth. That's when I know this person needs help, because we need to help them gain that confidence so that they do not put their hand over their mouth and smile freely. Okay, so there's lack of confidence there. We need to build that confidence. And there are certain cases where people will avoid social gatherings. I know young adults where they avoid social gatherings altogether. And there are young adults who get bullied a lot because of spaces between the teeth, or because of the teeth being a lot in front. And this will lead to a lot of unhappiness, and which in turn may cause depression, clinical depression. So we need to pick up those signs. So that is the psychological indication. When the patient is unhappy with the way they smile and they're not able to smile freely, that's when we need to help them. So one of those cases was one of the patients who walked into my clinic. This particular lady, when she walked in, she was not unhappy or anything, but the only thing when she walked in, and when I tried to crack a joke with them, And when they keep their hand in front of the mouth, I know they're not confident, and that's when they need help. And this particular lady did that. So as you can see there, she has a large amount of spaces. So this is a very clear-cut indication for an orthodontic treatment, and not just dental veneers. You see, so the proclination is, it's highly proclined, the teeth. There's a large amount of spacing. So we need to do orthodontic intervention in this kind of a condition. I will go to developmental indications. So developmental are simple: when there are jaw discrepancies, when there is a case of class 2 skeletal pattern, when there's a case of class 3 skeletal pattern. Class 2, if it is a young child who is pre-pubertal, then if the VTO is positive, then we go ahead with the twin block appliance. I think I have one case like that. This young boy, pre-pubertal young boy, he's around 11 and a half years, if I'm not wrong. VTO was positive, so he was indicated for twin block. So in this situation, developmental, so intervention, so two-step treatment we do. We go ahead with functional, and then we go on with conventional orthodontic braces. Then even when there's class 3, so that's when you have to do an early intervention. You can go ahead. I'm giving very simple examples, like you can go ahead with the chin cup, or depends on the case. You have to do a thorough study. You have to do the cephalometric analysis. You have to get your numbers, and you have to decide what to go for, whether you have to do arch expansion, whether it's going to go for headgear. However, in such developmental issues, an orthodontic intervention is required. At least a consult from an orthodontist is a must and should. Then you have functional. Functional indications in psychological and developmental. I've seen this child as well, was very shy, extremely shy, was even shy to talk, because when she spoke, they could see her teeth. And this particular child was bullied in school. So here also you have a psychological indication, a lot of crowding, and this child needs an orthodontic intervention right away. And that was done for her. And then you have functional. Functional indications would be like a traumatic bite, where you have a cross bite, a deep bite, an open bite, or if there are habits like this mouth breathing, there's thumb sucking, that's when we have to intervene. And examples of traumatic bites I have here, you see there we have a anterior cross bite. This is a very traumatic bite. If this child goes on in future to continue with this kind of bite, for sure she's going to have problems with these teeth, anterior teeth, and she might undergo periodontal issues and many other, several other issues. So in this kind of a situation, orthodontic intervention is a mandatory step that we have to take. This is for restoring her functional aspect, because this particular bite is traumatic. It needs to be corrected. Another traumatic bite. Here we see a deep bite, especially that central incisor. So this particular young adult also needed an immediate intervention, orthodontic intervention, very much needed. So this is also again a traumatic bite. So functionally we need to correct this. Another next indication, we will go to trauma or disease indication. So for example, trauma or disease, this would be when a child would prematurely lose teeth because of decay. If there is a risk of trauma, see, we have seen children who have severe proclination of the anterior teeth. That's when early intervention is done in order to correct that proclination, so that the child does not have trauma while playing sports, or when there is high chance of trauma by falling down to that in central incisor, then intervention is required. So when there is excessive proclination of the anterior teeth, even in some cases bimaxillary protrusion is done. And the disease indication would be, see, in certain kinds of conditions where there's, like for example, I showed these kind of traumatic bites where you have a cross bite anterior here, this particular area, and here you have a deep bite. So what will happen is, in this deep bite and cross bite, and even in reverse overjet, which I will show next, you will have issues like periodontal issues in the future. So we don't want that. We want to prevent that. If we can catch a child early or a young adult early, if they come to us at the right time, I would be very happy to give them a better bite, better functionality of a bite. And the next indication would be impacted teeth, when there are impacted canines, impacted premolars. Then an orthodontic intervention, an orthodontic consultation is a must and should. And one more very common is agenesis of lateral incisors, and then you have spacing between the central and canine. And when there is agenesis of lateral incisors, there's several, there are 2-3 treatment techniques that we go ahead for. If there is space enough, like there's larger amount of space between the central incisor and the canine, then we keep the space patent or increase the space, and then we call in the orthodontic consult, and we might go in for implants or a prosthetic rehabilitation after the orthodontic treatment. If the space is not enough, then we close the space. We close the space completely. We give a favorable bite to the patient. And after that, if the patient wants, the canines are then shaped into lateral incisors in order to give a more aesthetically pleasing smile. And in some situations, the patients don't even want the canine to be converted into lateral incisors, and they're very much happy with the canine being in the position of the lateral incisor, and they let it be. So you can do that as well. Now, this is one particular case that was very interesting that came to me. This child had a very prominent skeletal class 3, anterior crossbite. Posteriorly, I don't see a crossbite. However, skeletally, she was class 3. Most doctors outrightly said she's a surgical condition, just orthodontic intervention, just dental correction is not going to help. However, what I noticed in this child was she had an anterior crossbite. However, posterior was not that bad. So I said, why not? Let's try. And it's just going to get better. So at least dental malocclusion, I can and I should be able to correct. And I went into it and did the extractions of the lower premolars, and slowly, gradually, we did the orthodontic treatment. You can see premolar is rotated there. I derotated it, and this is the present day. I haven't debonded it yet. I still need to do the finishing. I gave her class 3 elastics, but see, from class 3 anterior relation, we've come here. For a child who could not, this child came to me referred from a speech and language pathologist, because she had gone to speech and language. She had multiple indications. First of all, she had an issue with speech. She could not spell her S's, F's clearly. So she had a constant lisp, and because of this, she had no confidence to do public speaking, which she liked to do a lot. Firstly, that. Secondly, also she was very shy, psychological. So there was psychological indication. The bite was traumatic, functional indication was there, and developmental to an extent, because she's a class 3 skeletal pattern. She came to me when she was around 16 and a half years. So not much I could do with functional. However, I did go in with extraction, and dentally we could correct. And from here, we came here. She was a sad young child who came to me, and she presently is happy. And just for that smile, I feel so happy, because she's happy. She's able to do public speaking. She has no lisp anymore. She's confident, and she's going on to do her professional degree. And very soon we'll go into settling, and we'll finish the case, inshallah. So alhamdulillah, we have come this far, and I'm very happy. I'm very happy with this child, and that child herself is very, very happy. So this is what orthodontics can do. Orthodontics can help you look better, feel better, and speak better as well. So it has multiple indications. This particular case had multiple indications. Now, after this, I'm going to just give you a chart. This is a chart between orthodontic and veneers. So just pit it against each other. I'm an orthodontist, so I always prefer an orthodontic treatment over veneers. However, there are places where veneers have proved more favorable than orthodontics, and we will see that. Orthodontics is invisible, like because aligners have come, it's invisible. But veneers, the biggest disadvantage of veneers I've always felt myself is the loss of enamel, loss of tooth structure. For me, it's the main thing. For me, I do not like tooth structure to be wasted away unless until it is mandatory. So there's an irreversible enamel loss in veneers, and we cannot deny that. And I feel, and so as I have presented here, it's orthodontics is a healthier alternative because it enhances the periodontal health, it gives you functional help, it helps you with your bite, etc. Veneers, I don't think they're a permanent solution because they might chip. I might have a lot of prosthodontists and aesthetic dentists who will not agree with that, but in comparison to orthodontics, it is not as permanent. Economical in the sense, orthodontics, when we plan an orthodontic treatment, we're looking at it to last for an entire lifetime. I don't want it to last for just a year, a 2, a 10, 20. No, when I'm going to do a treatment, orthodontic treatment for a 16, 17-year-old, I want this result of this treatment to last their entire lifetime. With that goal, I go into the treatment. It's not, and as we know, because veneers are prosthetic material, they don't have a life, they might have a lifetime of more than 12 years, but in general, this is a gross number, 5 to 12 years. And we can, in orthodontics, you can rearrange the teeth, you move the natural teeth, and also you can correct the bite, you can fix traumatic bites, and you can fix speech issues with orthodontic treatment. Veneers would not be doing that. It's only cosmetic, and there's not a lot of therapeutic value to it. That's why this is the difference, gross differences between orthodontic treatment and dental veneers. But there are situations where we do both together. And like I said, when there is agenesis of lateral incisor, and when we move the canine into the space of lateral, and you have to get in the aesthetic or the prosthetic consult, and you have to place, you have to change the canine as you change the appearance of the canine as the lateral incisor in order to give a more aesthetically pleasing smile. So this is one of those cases. I want a small case discussion. At this point, we will have this small case discussion. This is a very simple case, very straightforward case, had come to me very many years ago. And we had done ortho and veneers for this particular patient. I want everyone to participate, give their views on how they would go about with this treatment, and where do you think, why do you think it is required, orthodontics in conjunction. Dr. Rafia, actually, you can come in at this point. We will have a short case discussion on this. About 10 minutes, and then I will finish off with my conclusion. I'll give you my conclusion, and then we can have a Q&A session. Is that good?
Sounds good to me, Dr. Sana. Do we have anybody from the audience who would like to pull in their suggestions or how they would have treated this case if it would have been in their clinic? Okay. Could you just give us a detail about this case, Dr. Sana? How old was the patient?
Yes, I will tell you. This patient is, one second, just give me 1 second. Yeah. This patient is around 25 years old, female patient, is going to get married in about 10 months. Okay. That's how she came to me. And she wants a solution. I have space between my teeth. I want to look good for my wedding. That's it. And what can we do best in the span of 10 to 11 months?
Would anybody in the audience like to pool in their suggestions? Yes, please, Dr. Zahiruddin.
Jazakallah khair. Thank you so much, Dr. Sana. Yeah, if this patient would have come to me, I was just looking at this. So I agree with that. I mean, obviously she has what's called as chipped laterals, irregular edges, just spacing, and attrition of canines as well as there. So I would level and align, correct the overjet overbite, and close the spaces, and then go for a cosmetic contouring and probably composite bonding or veneers if the patient wants to go with veneers. But I think both has to be done in this case, with orthodontic alignment and as well as cosmetic bonding.
Yes, yes. That is absolutely right, actually, because if you can see very closely, the shape of the teeth, they're chipped everywhere, like the incisal edges, even in the central, you can see they're chipped. However, they're also not aligned well. So you need to align this teeth, you need to close the spaces and then go in with the veneers or composite restorations. Veneers would be more permanent, composite would probably chip more often, that's it. Anybody else?
At a certain point, Dr. Sana, what would be the regular, say, a case like this walks into a clinic? The first thing, if say for orthodontic treatment, definitely a specialist would intervene.
Yes.
But what would be, according to you, what would be the initial things that you would communicate to the patient, knowing that the patient has an expectation of the entire treatment, whether it's orthodontic or it's aesthetic, to get over, say, within 10 months? What are the things that you would do, especially such cases? I think we had a short discussion on this in the group itself. Patient come with unrealistic expectations, like I have a marriage, or I have to go to a certain place, or I'll be shifting out of the town in a specific time period. Then as a clinician, you understand that, okay, you will put up, say, if it's an orthodontic treatment, you would put up force on the teeth and aligning them, but the bone reacts differently in one person to the other. There are different factors involved, the etiology, the functional aspect, whether the patient has a habit. If the habit is not in control, no matter what treatment you do, the treatment might relapse. You check in the periodontal health. Again, if the periodontal health is not taken in consideration, any kind of treatment would relapse. So in such cases, what as a diagnostic aids would you prefer? And what would you do or communicate to the patient to lower down the patient's expectations?
First of all, you need to, first when the patient walks in, we need to have a very clinical examination. First, history taking on the table first. You need to talk to the patient. You need to understand what their issues are. The first question I ask to any of my patients is, first of all, I observe them. I observe from the time that they're walking in. So I'm observing their hand movements, their confidence level. As I said, when they're laughing, so I'm observing everything actually. When they walk in and they sit down with me, I take a brief history, medical history, a dental history, whether they've had any negative impacts about dental treatment previously. So see, that also has a lot of influence. And once I've taken my history, then I take the patient to the chair and I do my clinical examination. I check the periodontal health. I check and age is a very important factor, and health, overall general health is also a very important factor. Oral hygiene is a very important factor. So based on all these factors, I do my clinical examination and I check for decays, I check for all the basics, if any other field is required, any other intervention is required, whether any other specialty is required, I look into all that. After that, I spend a lot of time talking to the patient before I start the case. So I communicate, I talk to them, I listen. In the first appointment, I listen to them. I want to know what they're expecting. If their expectations are beyond my, beyond my capabilities, or they're expecting something more than I can give, then I will tell them that. I'm going to be straightforward, upfront, and be honest. I'm going to be honest. The thing is, I'm not going to scare them. I will never scare a patient away, but I will not lie to a patient. I will always be straightforward and honest. I will try to understand what they want. This particular patient was very cooperative. Let me say that. She had 10 months. She was not expecting to have the perfect smile. She said, just if you can close the spaces, doctor, I'm very happy. So that, see, such a patient, she's not expecting much, but then you would want to give the best to her. Yes, as you said, there are patients who are going to ask, who have very unrealistic expectations. And if you cannot meet those expectations, and if you think the patient is demanding a lot more, and there are limitations, there are restrictions, because after all, we're dealing with a body, and one body is different. And then they come and they'll compare themselves to other people, that, you know, my friend did it in 6 months, you know, why can't you do it in 6 months? I'm like, no, your friend is different, and your friend was treated by another doctor. I don't know about her case. So I'm upfront, I'm honest. I say it with kindness. I say it with respect, but I still say it. I still say it honestly. If I cannot meet your expectations, I can meet this is your issues. I write it down. You have other issues, like if they have periodontal issues, they have age factor, and etc. etc. I jot it down. See, this is the constraints I have biologically, and this is the time frame I will require minimum to finish this treatment, provided you come every month regularly to me, provided you do not come back with breakages, then this time frame is applicable. Otherwise, this time frame also gets extended. So I communicate everything upfront, take a consent. After I do that only, I start the treatment. So I think communication is very important. You have to first understand the patient, their psychology, their expectations, and then you have to deliver. Then you have to, first, I feel any patient wants to be heard. Any patient needs to, any patient needs to be heard. The first 5 to 10 to 15 minutes, I let them talk. I say, what do you want? What do you think is wrong? Why do you think you need orthodontic treatment? Why have you come to me? You tell me what you want from me. So I listen. First 15, 20 minutes, all I do is listen. So I get a lot of teenagers. Teenagers are never given the time of the day to listen. Teenagers are always told what to do. When an adult sits with them and actually tries to listen to what they're saying, they feel happy, they feel comfortable, they feel confident. And then you can, you know, understand their psyche, their psychology, and then communicate with them. See, you have so limitations. I cannot expect, I cannot give you that. And please don't compare yourself with somebody else. So I think communication, Dr. Rafia, you have to communicate to them. And with time, you will learn that it's better to tell them upfront than to take up the case and halfway through, you know, they expect something else, and you don't want that. You don't want that. So I tell it upfront. I tell it in the beginning, and so that I have no issues halfway, midway, anyway. So my patients, Alhamdulillah, I have not had those issues here. So I communicate a lot. I take more time in the first few sessions. I spend a lot of time. I'm not in a hurry to bond. I don't do that because I'm not in a hurry to bond and start cases, this number of cases. I want my patient to be happy from day one to day end. When my teenager or my patient leaves the office, I want them to be happy. That's my most important goal. Only if they are happy, then I'm happy. So to get there, I need to do a lot of prep work, talking.
Absolutely.
I talk a lot.
So we have a question from Dr. Ramiz. He asks, won't digitally showing the patients help in conveying them what they should expect?
I mean, digitally, the Veneers and the entire treatment plan, you're saying?
I guess so. Dr. Ramiz, if you could unmute yourself, is that what you mean by the question?
You mean the entire orthodontic treatment or in conjunction with the Veneers?
I am not able to get a response from.
I can't hear it as well.
Yeah. So
yes, I can. You use all the technology you have. Please go ahead. To each his own. As long as you, understand the patient and convince them and make them understand that, this is the time frame it's going to take, and these are the methods of treatment. There are different kinds of techniques we use. You can select. I think you can use any digital platform, and today there's so much digital data available now. I think we should utilize it. That's a good idea, actually.
And also, if you have a referral of such cases, for example, you have anything in particular, if a patient comes to you, says generalized spacing, definitely if you haven't done those cases in past, or you have Google, it's a world full of knowledge. So you can just pick up images and you can just show them that.
You should always show cases.
Yeah.
You should always show your previous. I do that as well. I'm sure all orthodontists do that.
Yeah.
Most of us, we show our previous cases. If we have similar cases, then we have our files. We will open. Earlier it was physical form. Now we show digital. I show digital form, like pre-treatment. I will not show the faces. I will only show dental part of the treatment. Yes, of course we have to show. And what Dr. Rameez is telling, entire digital, change. I know what he's trying to say. That also many people do. We can do that. That's a very good idea as well.
So it's very similar to what are done in the softwares for aligners, especially.
Yes, I wanted to mention that. In aligners, that's what they do. Software aligners, but the aligners are done by general dentists as well. So, the entire treatment plan the lab will give you. Entire digital change of the teeth as such is given and is shown to the patient, and that convinces the patient a lot, actually. It's a good idea.
Yeah, and presently we have a number of softwares apart from certain aligner companies, which come from Ormco, which come from American Orthodontists, which you can buy and you can keep it with you. Yes,
right,
that's a lot
now
of.
there's a lot of digital
Yes.
data available. Now you can put in, bring in changes. So it's really amazing, actually. It's beautiful when you can combine technology with the, science, like biology. When you combine the two, it's beautiful.
I hope that answers your question, Dr. Rameez. Do we have any more questions from the audience? You can unmute yourself or put up in the chat.
I'll do one thing. I'll go into the conclusion now. I'll finish the conclusion, and then we can have a Q&A again. Yeah, how about that?
Great, sure.
All right. Okay. So in conclusion, orthodontic treatment and dental veneers both happen to be comprehensive treatment options. However, choosing both between the two can be challenging and is dependent on multiple factors, as we have discussed. Long-term benefits in conjunction with practicality need to be balanced in order to achieve the desired result. In some scenarios, a marriage of both treatment options will help us reach the goal, and we can deliver the most optimum outcome. So as we discussed in the previous case, a conjunction of both treatments is also extremely favorable. Hence, a thorough analysis of the case is vital. Also, patients' expectations. As you said, Dr. Rafia, this patients' expectations have to be understood before a treatment plan is chalked out. So for me, always this is number one, patients' expectations, because they would probably look at a Hollywood smile and then they come to us with chipped anteriors and they say, I want just like that, same color. I want exactly smile like, and I had a patient who said, I want to smile just like Angelina Jolie.
Oh, I agree. I had one patient. I want smile like Shah Rukh Khan. We discussed it a couple of times.
Shah Rukh Khan doesn't have a very nice smile.
But the patient was a fan, so Hollywood smile is something. They come with those expectations that orthodontics cannot change the shape of a tooth. We can change the position of the tooth, but not the shape. That's very important to communicate across to the patient. We have. Should I take up the questions?
Good.
We have Dr. Arshia asking us, Doctor, you have spoken plenty about the pros of orthodontic treatment. Can you highlight a few limitations of the orthodontic treatment?
Limitations of orthodontic treatment.
Yes.
Age, and when after a certain age, when the bone is not, then I do not recommend orthodontic treatment. Patients on bisphosphonate therapy, it's an absolute contraindication. Patient with uncontrolled diabetes mellitus, diabetes, insulin dependent diabetes, uncontrolled, not recommend orthodontic treatment at all. So there are limitations. Also, patients undergoing not in the remission period, but are having cancers, and we don't recommend. It's a slight contraindication. Yeah. So there are certain systemic conditions where we don't recommend orthodontic treatment at all after a certain age. And retreatments, I've had a patient recently who's undergone treatment for extensively orthodontic treatment for the past 3 years, was not happy, was not satisfied, has had bone loss, posterior, molar bone loss and everything. So I said, no, she's also, patient is particularly 45 years. And I would say I wouldn't recommend orthodontic treatment. And again, treatment for such patients. So conditions where the bone is not healthy, the gums are not healthy, where the oral hygiene is extremely poor. When the oral hygiene is extremely poor, and especially if it is with a young patient, I don't start right away. I say, I want you to improve your oral hygiene, and I'm going to observe you for 3 months. And in 3 months, I see improvement in your oral hygiene. That's when I'm going to start your braces. That's what I do. So in cases of even poor oral hygiene, I do not take up, because I know if I take this case up and we put the braces in already an existing poor oral hygiene case, this is just going to get worse.
All right. Doctor, could you stop sharing the screen so that
sorry. Okay.
could have.
Okay.
Great. Thank you. In addition to that, I feel when the patient, as doctor mentioned earlier, Dr. Arshia, if the patient is in hurry of treatment, getting instant results, dental laminates or dental veneers are also called as instant orthodontics. So if your patient is like, बस जी एक हफ्ते में हो जाना चाहिए, or I need it instantly. So I definitely orthodontics there would not help.
Absolutely.
So
Time.
Yes.
Time is a big factor. Yes. If they don't give me time, then I'm not going to do it.
And also with instant orthodontics or dental veneers, we have seen instant gratification. Patient is instantly happy with the results. So that is like an advantage of dental laminates over orthodontic treatment.
Yes,
and and obviously, as Dr. mentioned, the other factors. We also have a question from Dr. Ramiz saying that space closure with ortho has a lot of relapses. So in such cases, would you recommend veneers?
No, depends. I don't think it's very, I mean, yeah, there may be cases, but you need to know why so much of, why the relapse is happening. For example, if there's a midline dystema, we were discussing this, right? So I always look for a high frenal attachment. So in such a situation, if the frenectomy is not done, then of course it's going to relapse. 100% is going to relapse. Even if you give the fixed lingual retainer, there are very high chances of it relapsing as well. So I believe in cases of spaces, especially, you should know why it's so much spaces, especially with midline dystema. If there is a high, if you can, and if there is a probable cause, eliminate the cause first, and then do the orthodontic treatment.
Also, we will be definitely, before you start with any kind of treatment, especially in cases of space closure, look for habits. Habits are really important. If the patient has a tongue thrust habit, you do whatever treatment you want to.
You have to intercept the habit, Dr.
Yes.
Rafia.
Yes.
Even whilst you're doing the treatment, you can intercept the habit.
Correct.
Either with exercises, or if that's not happening, then you put lingual braces, it will.
Correct.
Like that, it's gone.
Exactly. So make sure
that is done. On the tongue and it's gone.
Yeah, true. Anyways, tongue is a very powerful muscle. Other ways also. So another thing that I would like to add is that make sure you are instructing the post-treatment instructions to the patient are very important. Make sure the retention that you're following with the treatment is extremely important. In orthodontic treatment, make sure you give retainers. That is
And
the
they wear
key.
it.
Yes, that's the
And
key.
take a written consent saying that you will wear it, and if you don't wear it, it will relapse. That's what I do.
So that is very important. Whether you are giving, nowadays we prefer fixed retainers, but in conjunction to that, there are a lot of practitioners who suggest Essex retainers.
I give Essex both. I give.
Yes, apart from giving fixed, but make sure the patient that is something that we cannot like. It's how the patient compliant the patient is in wearing the retainers. So to eliminate that factor, I think fixed or lingual retainers is a safer option. Make sure you are instructing the patient to take care of the habits, because it is very difficult, even when you're intercepting the habits, they will take a time. They will take a lot of time to get rid of that habit. So make sure the exercises you're giving, or if you're giving any appliance, that is being continued. In your, say, post your removal of the braces, you've given the lingual retainers. I would suggest giving removable retainers with the tongue crib, so that the patient can wear it in the night and get rid of that habit continuously. Those are the things. In that case, recommending Veneers, again, it boils back to the basics. You have to eliminate the habit first. You have to make sure that there are no impacted mesodents, there is no high frenal attachment. Even Veneers are not going to help there. So I think that's important. Would you like to add something else, Dr. Sana?
So you have to give very good retention, which is important, and the retention has to be followed by the patient is also very important. That aspect we cannot say. So I suggest that, we take consent before treatment, we do that. But I also suggest when you're taking, when you're debonding, consent for debonding and delivery of retainers, I have a consent for that. So in that, I also clearly mention, if the retainers are not worn for such and such time period, the chances of relapse drastically increase. And then the doctor does not become responsible for it. So I take a signature, and then I take signature from witnesses as well.
Dr. Basha, we'll yes, come to you. I just want to brief it down with the second question Dr. Arshia asked. How do you plan diastema closure? I think we already did hit on some of the points in the previous answer. There are plenty of options. So how do you narrow down?
Okay. See, diastema closure, when patient comes to me with the diastema primarily, I will first do a clinical examination, and then I look at all the frenal attachments first thing. And invariably, if not all, more than half of them have high frenal attachments. So the first thing I will communicate to the patient, saying that yes, we will go ahead with ortho treatment. You do need ortho treatment, definitely. But however, with that, you will need a minor surgery, which will disconnect the frenal fibers and connect it up higher, which is called frenectomy. And this will help you from the teeth going back to the original position that they were in post-orthodontic treatment. If you don't undergo this treatment, this minor surgery, a very small surgical procedure, the failure of orthodontic treatment becomes very high. So I communicate that. And once all that is done, we go ahead, we schedule for a minor surgical procedure, frenectomy. The surgeon does it, finishes it up, heals in about a week. And we do the pre-orthodontic prep, and we do the cleaning, polishing, and we bond the case. That's how I go about it. And after that, I prefer to give a fixed retainer in the upper palatal area at least, including Essex. I also give Essex. I give lingual fixed retainers for the lower, plus Essex in generalized all cases. But in this particular midline diastema, I prefer to give upward lingual fixed retention as well. And I also give Essex because I'm very unsure about teenagers. They'll say yes, 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 and then they go ahead and then they lose their Essex. So then I have my lingual retainers in place. and they lose it in school, they lose it in college, their younger siblings break it. So I try to keep myself as safe as possible as a doctor and as an orthodontist. I want my patients to have very good success, and I want the treatment to last for a lifetime. So for the 12 months period, I want it to be retained in that position, because I know once the bone is formed, mostly it will not relapse. So I give good retention, and that's how I go about with midline diastema. If there's too much spacing, then of course just orthodontic space alignment will not help. You will have to go with the prosthetic consult or aesthetic consult. And that's when veneers or whatever the prosthodontist, I cannot comment on that because I'm not a prosthodontist, right? So prosthodontist will have to comment on that, and whatever that treatment, in conjunction we work with the prosthetic or aesthetic dentist, and it becomes a multidisciplinary approach to the case.
All right. Thank you, Dr. Sana. Dr. Basha, so would you like to unmute and ask the question?
Hello, Assalamu alaikum. Can you hear me?
Yes, yes.
Walaikum
Yeah.
salam.
Yeah. Very good presentation, Dr. Sana.
Thank you, sir.
Yeah, one question asked by Ramesh was, post orthodontics, the diastema closure usually fails. One of the things which we overlook was supracrustal fibrotomy procedure, which has to be done regularly, once in 3 months. This usually helps in minimizing the failure, because transseptal fibers takes a lot of time to reorganize. I just wanted to add that.
He's right. He's absolutely right. But for this, no patients, you have to have that rapport with the patient to keep coming back. That's all.
Yes, yes, I agree.
Yeah. That you need.
Thank you, sir, for adding that point. Do we have any more questions from the audience? Dr. Fayaz, would you like to unmute yourself and ask the question?
Hi.
Hello.
Hi, Dr. Sana. Yeah. Nice presentation. And what I want to ask is regarding, I do a lot of veneers, and you know that.
Yes.
And yes, especially a lot of cases come to us after orthodontic treatment. Most of the cases, especially what I see right now in Dubai and Sharjah, they do have a history of orthodontic treatment. And generally they come to us after, when they want to get married, or even after marriage, they want to look a little better, those kind of things. And it's like famously known as Hollywood smile and things like that. Now, yes, in most of the cases, orthodontic treatment at the teenage is required, and to make them look more beautiful, make them look more confident in the public life or in their career, they do come for veneers to us. It's a combination of both in most of the cases. Now, what I want to understand, or I want your opinion, is the introduction of artificial intelligence to our, especially orthodontic field. So we do have aligners today. We can program the whole treatment. We can show them virtually how the treatment can happen. And we can show the step-by-step and things like that. And it's really picking up all over the world, even in India and in the Middle East, and definitely in the Far East countries and Western countries. Now, taking this into account down the lane in next 10 years, do you think orthodontists will have a job to do, or everything will be taken over by a technology, where we can really do everything virtually and give them those, print them CAD/CAM using, and we can control the complete treatment? I just want to have your foresight or view on this, both of you.
Okay. Shall I go first, Dr. Rafia?
Even Dr. Asim Basha sir can throw light on this.
Okay.
It will be good because he's the most
Who
senior
wants to go
orthodontist.
first? Dr. Asim wants to go first, or?
Yeah.
Okay, I'm going to say. See, first of all, it's very nice that all this is happening. The technology is happening. I really encourage.
Or in a nutshell, can I ask you that orthodontics is a dying specialty?
I don't think it's a dying specialty. Answer is no. And I'll give you my reasons for it. And I will never say it's a dying specialty. I'm an orthodontist. I've told you that earlier. So there are several reasons. I welcome the new changes. They are very nice, and I'm very glad that the artificial intelligence has come into our field and giving the entire treatment plan and correcting. Now, I would just like when you saw my presentation, there were a couple of cases. You know, I showed you traumatic bites, if people can remember, and I also showed you the skeletal class 3. Now, simple question, right now at present, these cases, can they be treated by aligners only? Rafia, you think it can be, Dr. Rafia, you think it can be treated only with the aligners?
With the liners, with Invisalign right now, the G6, G8, they are coming up with even the twin blocks and reverse twin blocks, but it will take a lot of time because it's a patient compliance device. So if you don't have compliance, yes,
primarily. Secondly, the amount of control that I have in my conventional orthodontics, I don't see that kind of control in Invisalign or any other ClearPath aligners. Invisalign is a tried and tested brand, is good, and has lasted in the market for a very, very long time, has given excellent results. I do not deny that. But the market at present has a lot of clear aligners doing the rounds. And their success is only dependent on the retention factor. Treatment is okay, but after that, how long is it going to be retained? Depends on the success of the treatment. So you can give an aligner, you finish it for 2 to 3 years, and then after that, how long is it going to last? How many relapses are going to happen with this? So there's still a lot of study that is involved in this, and it's still going to take time. It might, I'm not saying it will not develop further. It might develop further, and of course there must be a chance that it may solve most, if not all, cases of dental malocclusions. But still, orthodontics, conventional orthodontics, to some extent, will still find its place in the dentistry. That's what I feel. And I would not like to believe that it's a dying field. It's something that I would not like to believe from a personal perspective as well. So I do not agree with that 100% as much as I welcome this new technology.
Dr. Fayaz, you have anything to add to it?
Shall I add?
So please.
Yeah, I want the senior orthodontist, Dr. Asim Basha,
Yes.
who's been practicing for so many years.
Yes, Dr.
Want to-
Fayaz.
Yes.
Yeah. See, what has happened is now orthodontics has become an interdisciplinary field. Before it was exclusively one field. Now our horizon has increased. Our area has increased. The level playing field has increased. Okay. Of course, the technology has come. Again, how and when to use the technology, again, orthodontist comes into play.
Exactly.
And every field, there will be a relapse. When the relapse occurs, the artificial intelligence will not work that time.
Exactly.
Again, we have to work. This artificial intelligence, believe it or not, we used to sit in our canteen in 95 and design. We used to say some robots come and move the teeth like this, so nice it will be, no need to see the patient. We used to sit there and we used to sit in the canteen and design. So we are seeing this now. So it's a very big field. TMJ has a problem has come. Orthodontics related to your neck pain, myofacial pains. This is there. You have got geriatric orthodontics coming up. I have treated patients around 80 years, 82 years, believe it or not. So it's a big, huge field it is. So it's never a dying field. Every learning is a continuously evolving process.
Exactly.
So it's a part of evolving, that's all. Once upon a time we had begs, we had straight wear, now we have self-ligating, now we have got aligners. Tomorrow something else will come. So it's part of us to accept it, and how we use it, it's our domain. So we have to upgrade ourselves, that's all.
And even if artificial intelligence kind of takes over, you will have an orthodontist behind that. So I don't think orthodontics is something that would be dying, not anytime soon.
Yeah, I hope not in our lifetime. I don't think so.
I hope so.
No, in fact, we have a lot of work.
Yeah.
True, sir.
Yeah, lots.
Thank you for your all opinions. Why I ask this question specifically is, see what has happened nowadays. This tele dentistry has come up now, especially for aligners. What they're doing is, they market it, and online people can call them back and they'll explain to them. The non-dentist explain to them about aligners. And trust me, this is happening in Bangalore. This is happening all over India now. If you look into that and if you try to talk to them. So what's happening is non-dentists talk to them about all the treatment of orthodontics, and they call them, somebody can scan, somebody will scan it, maybe a dentist, a non-dentist, just they scan it and they provide the aligners and everything. Most of the things are done virtually and they're just called once in 3 months or once in 6 months. And this is happening. This is happening right now in the market. So when I look into all this, what is the role of orthodontics? Yes, you people are right. Dr. Asim Basha, sir, and Sana, and all of you, Rafia, all of you said rightly, and you showed some difficult cases. But the most difficult cases, when you take up 100 cases, probably the most difficult cases will be around 10 or 8 or something. A lot of cases are simple cases, what we treat day to day. So most of the cases, like 70 to 80% of cases which we treat day to day are simple cases, having mild spacing or mild rotation or mild things. So only those 10 cases which you really showed very bad cases, we definitely need specialists. A good understanding of different specialities, interdisciplinary approach is required. So a lot of things. Sometimes I see females with missing teeth in front, then they need orthodontic treatment. We do put riding pontics, we do manage the spacing, then we do, after orthodontic treatment, we do the prosthetic rehab. So all these things are there. But when I look into the market, what's happening around us, and I look into the artificial intelligence which is coming up, then this corporate world which is conquering dentistry, when I look into all these things, so probably by 2030 or 35, that's when I see orthodontists will have a very, very small role to play clinically, because everything will go into, virtual world or things like that. That's why I raised this question. Anyway, thank you for your opinion.
I have one thing to add to this.
Assalamu alaikum.
Assalamu alaikum.
Dr. Nadeem.
Nice presentation, Dr. Sana, and nice going, good discussion. I think Dr. Fayaz has just opened the Pandora's box now. The discussion has gone on a different tangent. See, nowhere our field is going to go 6 feet under for sure. The corporate world, which is doing the kind of marketing about the aligners, it's a guillotine hanging on the neck now. See, it is basically, you can tell that this is blessing in disguise to the orthodontic clinicians at present scenario. All the spoiled cases which has been happening in the corporate world are the cases which is coming back to the private practices. I think Dr. Asim would surely agree with this. If Dr. Asim is online. Don't you agree, Dr. Sana?
Yes, sorry.
Yes, definitely.
Yes, it has happened. Actually, this is what I wanted to mention, that, relapse cases of aligners, they come to me on a daily basis. They've gone through aligners for 2 years and they were not able to correct most of these malalignments. And then I have intervened, done the conventional orthodontics for about 12 to 18 months, finished up, wrapped up, retention, and they are happy. So the thing is, any new, as I said, Invisalign is in the market for a very long time, but the new things that have come, only time will tell how long they're going to last, whether they're going to be able to retain the treatment. Orthodontic treatment does not just comprise of the 12 months or 18 months or 20 months of treatment that we do. It comprises of, the retention as well. It should retain, and of course, every doctor will have patients which will have relapses, but aligners, regular aligners, I've had a lot of patients coming back to me with higher number of relapses. And then they go in with conventional orthodontics, especially cases like class 2, class 3s. As I said, simple cases, there are majority, but also there are a lot of cases which are the severe crowding, even minor crowding. Sometimes the simple aligners are not, regular aligners which are not Invisalign cannot correct it, is not able to correct it as well. And I've seen it personally. Invisalign does a good job, but Invisalign is also extremely expensive and very heavy on the pocket and takes a very long time to finish the treatment as well. A simple case also takes a much longer time than conventional orthodontics. And It can be used on growing children.
Exactly.
I have
And
not
see,
seen
not
it
all
being
now
used in
is-
growing children.
Yeah, exactly.
I cannot
That
recommend
is what I meant.
Invisalign,
Most
even
of the
if it is the
clinicians,
best,
with the
to a
advent of
teenager.
the
I will
latest
not do that.
technology.
Sorry, Dr. Nadeem, you were saying something.
Very true. Yeah, sorry to interrupt. As Dr. Sana was spot on with the aligner treatments. I think there was a detailed webinar given by Dr. Firoz last time about aligners. The issue now with the corporates is they don't want to get into the metal brackets or the ceramic brackets. Every case they want to treat with aligners, which eventually fails. So this is what I said a few minutes back. The failed cases are coming back to the regular practitioners who are practicing. And it is more the headache to solve the issue, which has already been complicated, which could have been solved in a simpler issue in a span of 2.5 years with a simple bracket system. I think Dr. Zahir has worked in. Dr. Zahir, if you're online, you can just unmute yourself. You have worked on two different. Yeah, you have worked in two different continents, one in Saudi, one in UK, and I think you know the exact the system how it goes on in these European
Yeah,
countries.
exactly. I mean, the point to make here is, I mean, if you look at the aligner system, what I can give comparison is like bleaching. Once the bleaching was became popular, every beautician, every nook and corner, especially in UK, they were doing bleaching. But once they realized the non-dentists, they're not qualified, even a simple thing as the bleaching, patient came back with so many complications, allergic reactions, they're not taking responsibility. The government stepped in, they put a regulation, and now it's all controlled. So same thing will happen to aligners as well. At the moment, yeah, it's happening. Even in my own family, one of my cousins, he went. Same thing happened. Like mobile dentistry. They came, they did a scan for a class 3. I say no way it's going to be corrected with aligners. They charge 20,000, and they don't refunding. And these are all cases piling up. They're just behind money. Makes patients convinced. Whatever way they have some good sweet chocolate cases. They show them, trap them. Like a honey traps. So, but it's not for long. So yes, for a serious practitioner, yes, Invisalign does wonders. There are practitioners who are really working on it. That case is that's fine. But as a routine, it's not going to last long. People have more headaches than having smiles on them. So I think it's a part of the, as I say, evolving. We will see the change, and everything will take its time to put its foot off.
Thank you, Dr. Zahir. Also, I would like to mention these DIY aligners. That is like a trend nowadays. We see it in India a lot. Presently, I would not like to name the companies, but we have had cases where after just 2 or 3 months, the company stopped sending you aligners. They have taken full amount, and the patient is like in a jiffy what to do, and they report to us. They ask for like intervention, and we somehow have to start from the scratch because there's nothing that has happened. Those aligners, the quality of those aligners is worse than Essex. Like we have better Essex retainer quality than those aligners. So and you can check the Instagram, the Facebook pages. The reviews are horrible. So I think there's a lot of awareness nowadays within the patients also. They do a lot of research, or rather window shopping nowadays. So I'm pretty sure, as everybody mentioned, they do come back to dentists like you and me for our consult or our intervention. We have one more question from Dr. Arshia. It's little a bit deviating from the topic, but yes, let's take it.
Dr. Rafia, before you get into the next question, I just wanted to mention, see, the IOS body is very strong in India. It's very strong. I'm very surprised that the body itself is not taking any action against these companies who are trying to promote on the higher level, and they are literally exploiting the general population in terms of the monetary issues. See, simple aligners where they are charging 20-25K, a normal individual will fall prey for that, where an Invisalign goes up to 2.5 to 3 lakhs. So someone who might think, when I can get a treatment for 20 to 30K, why shell out 3 lakh rupees? So I think the IOS is a stronger body. I think they could have intervened this, and they could have stopped. So I'm very much surprised how come this is still going on.
What might come to a surprise to you, Dr. Nadeem, is that some of these DIY aligners or in-house aligners are done by orthodontists themselves. We have a couple of orthodontists who are, say, really high profile orthodontists who are owners of such companies. Dr. Nikhilesh Vaid and a couple of other orthodontists in the iOS have talked about the rise in such DIY aligners, but till now, as you mentioned, we have not had any solid step taken towards it.
Thank you.
Dr. Fayaz, before we come to you, I'll just take a quick question from Dr. Arshia. Dr. Arshia asks, what is your take on self-ligating braces? Is the cost a reason that orthodontists still go for traditional braces?
No, self-ligating is good, especially in crowding cases. Very good results you get. Self-ligating is a good system. It's not about the cost. Here we charge the same for MBT and self-ligating. I do not charge separately or differently. It's the same cost. It's just case selection. Depending on the case, if the case requires self-ligating, then I go ahead with self-ligating. If the case requires traditional MBT, then I go for traditional MBT, depending on what kind of mechanics you'd want to use, friction mechanics, frictionless mechanics, based on that.
Also, you have to give the patient all the option when the patient steps into your clinic. Self-ligating in India, in Indian market, yes, it is charged more than your regular conventional brackets. But there are a lot of patients who like to go with self-ligating, especially in cases, as Dr. Sana mentioned, where we do not want to extract the teeth, but at the same time, a little bit of expansion, slight IPR will help. Using of copper nitride wires with the system helps a lot in expansion. And we have, yes, there are restrictions to that also. There's a certain amount of expansion that you can achieve with self-ligating brackets, but we have, if you are educating the patient well about the pros and cons, say, of both the mechanics, you can leave it up to the patient, what the patient wants.
I would place it on case selection. For me, it's mainly case selection. If that particular teeth will favor, I will get a better aesthetic result with self-ligating, then I go ahead with self-ligating. That would be my call. Yeah.
Do we have any more questions before we wind up the session for today? All right, Dr. Sana, I don't see any more questions. You can go ahead with your closing notes, and then I would like to conclude.
All right, thank you very much. Thank you everybody for giving me this opportunity. It was a beautiful discussion. I think we had a very, very fruitful discussion. We touched upon some very important topics. We also opened a little bit of Pandora's box, and we had a good discussion about that as well. Which was very much needed because, you know, presently in the market, we've got a lot of such aligners, and we needed to talk about that as well. So thank you very much. And I hope we have more discussions like this. And I've had a very nice 1.5 hours. I hope everybody has enjoyed it as well. And hope to see you all soon, inshallah. And Jazakallah khair. Thank you so much. And take care. Alhamdulillah.
Thank you, Dr. Sana, for an amazing presentation. And I would like to thank everybody who joined in us today for their valuable time. I would like to thank the core team of GDP for creating such a fruitful platform for everyone. And let's hope and pray that we continue such series of webinars, and there is always and interaction. There's always a discussion. Let's learn from each other. Thank you again, and have a wonderful rest of the evening. Thank you. Allah Hafiz.